All right, this is chapter 37, caring for clients with central and peripheral nervous system disorders. We kind of talked about a lot of these the other day, actually, but I just kind of want to go off where we left off in lecture. Let's see. So we stopped with ALS, and then this is kind of where we left off. So this is cranial nerve disorders continuing. So this is trigeminal neuralgia, very painful. It involves the fifth cranial nerve, which is the trigeminal nerve. That's obviously why it's within the name. And it has three branches: mandibular, maxillary, and ophthalmic, meaning eye. So it's kind of around like that whole region of the jaw up into the eye. Usually this nerve is responsible for chewing, facial movement, and sensation. So basically what happens is it's a compressed nerve, and it compresses that trigeminal nerve root, and it's extremely painful. So it's very sudden, it's severe. Some people describe it with like burning pain. Not very comfortable at all. Diagnostic findings, they might do an x-ray of the skull, MRI, CT scan. Sometimes they can surgically kind of go in and, give some type of permanent relief. They will obviously try other things, instead to control that pain or decrease that into a manageable way before they're going to go in and actually resect that nerve. So we kind of want to know where it's at, if there's any certain patterns or events that are associated with pain, like is it stress-induced? Is it when you eat cold stuff? Whatever. And then inspect the oral cavity for signs of injury. And that's kind of trigeminal neuralgia. Like I said, it's not life-threatening or anything, but it's extremely painful. So definitely going to have an effect on that patient's, quality of life. All right, so next we have Bell's palsy, which I'm sure some of you are familiar with. It's kind of scary because if you've ever seen it or, know what it is, it can sometimes mimic signs of a stroke. So basically what happens is there's inflammation around one of the facial nerves, and so it just kind of blocks that motor response. So essentially it looks paralyzed kind of. Some people think that there may be some type of viral link, like if you get a virus, this could be, secondary to that. However, it's kind of unknown as well. And so usually there's facial pain behind the ear, numbness, diminished blink reflex, ptosis of the eye. This is like drooping of that eyelid. So like I said, it really kind of mimics a stroke. So some people, or like the facial, I guess, aspects of a stroke. So some people freak out. I would freak out. I had a coworker actually when I was a server. He was kind of complaining of it, and by the time he actually got diagnosed with it, it was so scary. He definitely looked like one side of his face, was completely drooped. And then there may be excessive tearing on the affected side. So diagnostic findings, obviously, usually with this one, you can see it. So based on symptoms and visual exam of the face. So what we want to do to manage this, usually we'll do some type of corticosteroid therapy. Remember, it's inflammation with that facial nerve. So if we can decrease that inflammation, that's going to help. And then sometimes we'll do an antiviral, like acyclovir. So anytime you see this acyclovir, it's usually, or it is an antiviral, but it's for some type of virus. So that it can inhibit the viral replication, so like getting it again, and it may decrease the time of the actual like inflammation and Bell's palsy. And then pain. If it is painful, definitely want to control that pain. We want to know, so as the nurse, we want to know the history If they've had any recent viral infections, definitely a head to toe assessment. Those cranial nerves, so when we're doing like that cardinal phylsic gaze, is it affecting anything? Do you see swelling on the eyelid? When you ask them to frown, smile, puff out their cheeks, move their tongue from side to side, that kind of stuff. That's what we want to observe for. And again, anything involving the face, we're worried about airway, right? So we want to see if there's any speech impairment. Are they able to chew? Are they able to swallow food? Because we don't want them to aspirate. That type of thing. All right. Next, we're going to go into Parkinson's disease. This is a deficiency of the neurotransmitter dopamine. So if you have a patient that has L-DOPA, that's usually what they have, Parkinson's disease. It can be very different levels, I guess, of severity. So someone you can visually see, oh man, they have Parkinson's, versus very slight. But yeah, so we'll kind of go into that a little bit. Again, a lot of these, unfortunately, are unknown causes. Sometimes they think it may be environmental. There have been links to self-administration of a synthetic form of heroin. Others have had, multiple head injuries, encephalitis. There's been links with this specific antipsychotic drug. So it's kind of just like a crapshoot, unfortunately, of what may cause it. But those are some examples. And then these are some of the assessment findings. So rigidity or stiffness within the body, tremors, pill rolling, we call it. The tremors are usually kind of what we see. Bradykinesia, mask-like expression, meaning like not very expressive. So a little flat kind of affect. Stooped posture, so you can kind of see this man's back is a little like stooped. Low tone speech, so hypophonia, shuffling gait, and difficulty redirecting forward motion. Diagnostic tests are usually, again, based on like the symptoms and doing a neuro exam. There's not like a specific like, oh, you're positive for this, you have Parkinson's. We talked about L-DOPA or levodopa, which they call as well. This is the one I see kind of more frequently. And so basically what happens, remember, it's a deficiency of dopamine, so we try to give them a little more dopamine. And help them, prolong their independence where they're going to need less help getting around. Also, PT, OT, family involvement, nutritional counseling. Again, this diagnosis is very holistic, so we kind of need all the things going on to treat it. Not treat. It's not treatable, just to manage the symptoms, I guess. Right. And then surgical management, there's like brain stimulations, which you may see. I always refer to the Grey's Anatomy episode. There's an episode where this man wants to walk his daughter down the aisle but has really bad, severe Parkinson's disease. And they go in and he's actually conscious, and McDreamy does a brain stimulation. And he like actually goes in and like finds the point in the brain where it's like messing up the tremors, and he's able to walk again, whatever. But it does happen. It definitely minimizes stuff. So here's some nursing diagnosis just for some neurological disorders. Huntington's disease, gosh, this one is not as prevalent anymore, but basically what happens with Huntington's disease is there you have your basal ganglia and portions of the cerebral cortex that start to degenerate. This one is genetically transmitted, and you can get it male or female. So the biggest thing we kind of see is a lot of mentation changes, right? So remember, cerebral cortex is responsible for a lot of like emotional processes. So that's degenerated. So that would make sense that this is what's kind of going on. So mental apathy and emotional disturbances, chloroform movements and grimacing. Sometimes they also have speech difficulty, loss of bowel and bladder, and then severe depression. So this is a really tough one mentally. So less, I guess, well, there are physical aspects, but yeah, it's pretty rough. Some of the diagnostic findings are PET scans. They can do genetic testing that can, try to predict a little bit more of whether or not you're going to get that disease. Medical management, tranquilizers, anti-Parkinson's drugs, relieve some of those chloroform movements, meaning kind of like, what's the word? Like disruptive movements. Not as smooth. And then genetic counseling, again, if you have 100% chance, I don't know if those are again, not genetics teacher, but of you passing down this gene to your baby, are you willing to take on that responsibility, whatever. And then nursing management, the client eventually will be completely dependent on others. Like I said, remember it starts with mentation changes, but we talked about loss of bowel, bladder, they're unable to chew and swallow, so definitely a hard task because they will eventually need full around-the-clock care, increased risk of pneumonia, contractures we talked about with those movements, so they get just tight and rigid, infections, and then we talked about aspirations, and then if their movement is being disrupted, obviously those pressure ulcer complications. And then just some more on Huntington's disease. So when they've done studies on it, there's brief episodes of abnormal electricity activity in the brain. And so sometimes these can cause high fever, electrolyte imbalance, uremia, hypoglycemia, hypoxia, brain tumors, drug abuse, or alcohol withdrawal. There is some different types of seizures here that they see. So you have your partial, generalized seizures. This happens kind of before those seizures, like the aura. People say that they know when they're going to have them. So we hopefully last week talked about seizure precaution. We did a little bit. Hopefully you went over in lab, seizure precautions. So definitely know those because I will be testing you guys on that. So basically we're just going to kind of go into seizures a little bit. This is one of the more important topics in this lecture, just because they're generalized and they can be onset by a lot of different things. And you'll just see them a lot more in the field. So what we want to know is clients' motor, sensory, neurological functions are normal, mostly, obviously, before, baseline. At the time of the seizure, these are just different types. So some people have, absent seizures where literally they're just, looking ahead. They're, almost in a daze and staring blankly ahead, but their eyelids flutter, or they have, lack of prominent movements. They're kind of just chilling. Our myoclonic seizures, that super excessive, jerky, kind of not a little more scary, but you definitely can see it. And then our tonic-clonic as well, so muscle alternate between contraction and relaxation, so super jerky, their hands might kind of tense up. So usually with these, we do EEG, lots of imaging of the brain to kind of see. When we talked about our alcohol withdrawals and stuff like that, this is kind of where we're talking about because our serum electrolyte levels are all out of whack usually, and it can send people into seizures. Dilantin is so a lot of these are manageable by drugs. So Dilantin is one, phenobarb, Tegretol we see a lot, Valium, to control seizures. We also see Keppra for seizure activity. And these patients need to be compliant with these medications. And sometimes you'll see that there is a patient that comes in and they're already on Keppra or Dilantin or whatever, and that threshold just changes of what they normally take in order to control their seizures. Now it's not working, so we need to either up it or change it or whatever. You guys should have talked about this in lab, so we want to make sure that if they are having an active seizure, they're positioned to the side, they're not wearing anything restrictive, the airway is patent, patient is sectioned, and oxygen is administered. And then definitely documentation that kind of supports that. So is there anything that preceded the seizure? Precipitating factors, like they had a super high fever before, we call them like febrile seizures in pediatrics, or they had an aura, how long the seizure was, if it was witnessed or unwitnessed, and did they hit their head, did they fall, anything like that. And then obviously we want to get their baseline vitals, oxygen sat, and probably a BGL. And then I'll quickly just go over, so this is brain tumors. Again, they can kind of be benign or malignant, just depends on the type of cells and where it's at. Sometimes it can be viral related, exposure to radiation, head trauma, or immunosuppression. Headache is the most common, and it's usually in the mornings. And then they become just severe. It's like the worst pain you've ever had, the worst headache. Some vomiting occurs without nausea or any warning. Papilledema, sometimes seizures as well. Difficulties talking, paralysis, and double vision. Again, just think like there is a mass pressing on something. So it kind of, again, just depends on like where it's at. And so what it's going to kind of involve. Our diagnostic testing, all this imaging, that makes sense. And then depending again on the severity, where it's at, all the things, can we treat it by surgery? Can we do radiation, chemotherapy, maybe all of them? Here's kind of some types of like different medications we could use, surgical options, and then some nursing management. These are pretty vague. I'm not going to really test you too much on there, but I did want to enclose that. So this is the end of chapter 37. All right. Thank you.